module will provide an overview of the pathophysiology of persistent pulmonary hypertension of the newborn. By completion of this module, the learner will be able to describe persistent pulmonary hypertension of the newborn, discuss the pathophysiology that results in a failure of PVR to fall, and identify conditions that may precipitate the development of persistent pulmonary hypertension of the newborn. When normal transition from fetal to neonatal circulation fails, the result is PPHN. This term is now commonly used to describe a syndrome characterized by common pathophysiologic features, including sustained elevation of pulmonary vascular resistance and hypoxia due to right-to-left extrapulmonary shunting across the ductus arteriosus. Sustained elevation of PVR can result in increased afterload on the RV. Over days to weeks, RV failure may occur, and ischemic injury can precipitate both RV and LV injury, as well as papillary muscle necrosis. These pathophysiologic findings are associated with a wide range of cardiopulmonary disorders such as meconium aspiration syndrome, sepsis, asphyxia, respiratory distress syndrome, and congenital diaphragmatic hernia. While many conditions may mimic the hypoxic respiratory failure seen in patients with PPHN, the clinical diagnosis should be reserved for infants with extrapulmonary shunting that contributes to hypoxemia and hemodynamic dysfunction. Recent estimates report the incidence of PPHN at 1.9 per 1,000 live births in the U.S. PPHN is often characterized as one of three types: maladaptation, excessive muscularization, and hypoplastic vasculature. This classification, while helpful as a generalization, is often imprecise, as patients may have one or more of these processes associated with their diagnosis. For example, a patient with CDH has both hypoplastic vasculature and abnormal muscularization of the pulmonary arteries. In maladaptation, the pulmonary vasculature is structurally normal, but the vessels are abnormally constricted. This is most commonly seen in clinical situations where lung parenchymal disease is present, like meconium aspiration syndrome, pneumonia, or RDS. Excessive muscularization is characterized by normal lung parenchyma with remodeled pulmonary vasculature. The pulmonary arteries have increased muscle cell thickness, and there can be distal extension of muscularization to vessels that are usually non-muscular. Hypoplastic vasculature is characterized by the underdevelopment of pulmonary vasculature. This is most often seen in the setting of pulmonary hypoplasia, as may be found in patients with space-occupying lesions of the lung, like congenital diaphragmatic hernia and large congenital pulmonary airway malformations. In these catheterization images, you can see the difference between a well-developed pulmonary vascular bed on the left and a hypoplastic, maldeveloped pulmonary vascular bed on the right. As this figure illustrates, there are many causes of and risk factors for pulmonary hypertension in the newborn, which all tie into the underlying pathophysiology related to increased PVR and hypoxemia caused by extrapulmonary shunting. Please pause the recording now and look through these diagnoses and decide whether maladaptation, excessive muscularization, or hypoplastic vasculature is the predominant cause of PPHN for each one. Of note, this list isn't exhaustive. Maternal exposures, such as smoking or the use of medications that contain aspirin or NSAIDs, are associated with PPHN. Maternal NSAID use in the third trimester and maternal hyperthyroidism are associated with premature ductal closure or constriction, which can lead to idiopathic PPHN. Maternal SSRI use is associated with an increased likelihood of PPHN due to vascular remodeling. Alveolar capillary dysplasia is one of the feared irreversible causes of PPHN. This is a rare and universally fatal disease caused by malalignment of the pulmonary capillaries and alveoli. In this module, we reviewed persistent pulmonary hypertension of the newborn, including the pathophysiology that results in a failure of PVR to fall, and identified conditions that may precipitate the development of PPHN.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.